Good morning, everyone. I'm going to present my findings on a paper that we are about to publish, the effects of Pterygium excision on IOL power calculation and its correlation with Pterygium size.
Sorry to withhold, sir. You are not a ratified member.
Sir?
You are not a ratified member.
Sir, I'm a member. I'm a presenting author. The chief author is Dr. Abha.
Whosoever is the presenting author, as per the rules, they have to be ratified members. So we will be marking your paper, but this will not go for the awards.
Sir,
Okay, that is what rule says.
Okay, sir.
If the presenting author is not a ratified member of AIOS,
Sir, I'm a member of the...
no, but you are Dr. Lakkshya.
Yes, sir, I'm registered.
No, not registered.
Okay,
The ratified life member of All India Ophthalmology Society. Your membership number is 29647.
By general body meeting also.
Okay, I'll clarify. Your membership number is 29647.
Yes, sir.
As of now, only up to 28,934 number is ratified.
Okay,
Beyond that has not been ratified. Maybe they will be ratified in this particular coming general body.
Okay,
So as of now, you are not a ratified member. We are marking your paper, but it will not go for awards. That is what is the information you must have.
Okay, sir.
Okay, sir. Thank you.
So prolonged exposure to UV radiation contributes to simultaneous occurrence of pterygium and cataract. It's a prevalent condition among elderly. A large pterygium can induce significant corneal astigmatism and consequently affect the accuracy of intraocular lens power calculation. The prevailing treatment for pterygium is surgical excision, which notably increases the spherical power of the cornea, while a significant reduction in the astigmatism has been observed. Calculation of an accurate IOL power is essential for enhancing visual and refractive outcomes in these cases, and till date, systematic studies are lacking on the predictability of IOL power in combined or sequential cataract and pterygium surgeries. Therefore, the study was aimed to assess the refractive accuracy of the calculated IOL power in these patients. Our prime objective was to compare the changes in IOL power before and 1 month after the pterygium excision surgery, and the secondary objective was the correlation between IOL power and keratometry with the size of primary pterygium. Our study period was 12 months, and it was a comparative interventional analytical study in the Department of Ophthalmology, SMSR, and our study population was 45 patients. Keratometry and biometry of all the patients was done prior to the surgery and 1 month after the surgery. All the patients underwent pterygium excision with conjunctival limbal autograft by a single experienced surgeon. The preoperative assessment included best corrected visual acuity, a standard slit lamp examination, dilated evaluation to rule out any fundus pathologies or any macular edema or any lens displacements. And keratometry was done, biometry was done using an A-scan, using immersion technique, and using a SRKT formula. The IOL power was calculated with the standard A constant of 118.2. Horizontal pterygium length and vertical width was measured using a Castro-Weher calipers preoperatively. Our inclusion criteria included patients from 40 to 80 years with primary nasal pterygium sizing from 2 to 4 mm, consenting for pterygium surgery, and exclusion criteria was previous ocular trauma or surgeries, and subjects with corneal ectasia such as keratoconus, dislocated or subluxated lenses, posterior staphyloma, pathological myopia, macular edema due to any retinal pathology. In the results, the mean age was 53 plus minus 16.2 years. Mean horizontal pterygium length was 2.3 to 0.9 plus minus 0.9 millimeters. The mean pterygium vertical width was 4.6 plus minus 1.1 millimeters. The mean keratometry readings before and after the pterygium surgery was evaluated, and it showed that the keratometry post-operatively increased to 45.35 plus minus 1.32, which came out to be significant. The axial length post-operatively increased up to 22.72 plus minus 0.68, and it came out to be insignificant. The reason for insignificance came out to be the biometry technique we were using. If we would have been using optical biometer, it might have come significant. The IOL power significantly decreased, and the corneal astigmatism also decreased. Post-excision stability of the cornea was that the astigmatism was reduced. IOL power shifted towards, there was a clear myopic shift of almost 0.3 to 0.5 diopters with due to corneal steepening. The size dependent changes was that the pterygium, more than 45% of the corneal radius or near the visual axis induce significant refractive alterations. Preoperative considerations were surgical planning. Surgeons was accounting for postoperative corneal remodeling when selecting the IOL power. So to finally conclude, due to irregular astigmatism and keratometric inaccuracy, there is a myopic shift after the pterygium excision. In the study, findings was that the IOL power was significantly less after the pterygium excision. The changes primarily result from the biochemical influence of the pterygium on the cornea, and its removal induced corneal remodeling. It was noted that the sequential pterygium excision and phacoemulsification surgery with implantation of monofocal IOL in an effective method than the combined technique, if the size of the pterygium was more than 2 mm. The key observation that the length of the pterygium contributed to considerable variability in IOL power, noticeable myopic shift, and the pterygium excision before cataract surgery optimizes our IOL power accuracy. And to conclude, in this modern world, when the patients are paying our high prices for premium lenses, an accurate IOL power calculation is very mandatory to for patient satisfaction as well as a medico-legal purpose. Thank you.
So your recommendation is if there is a pterygium of more than 2 millimeter, you do the pterygium surgery first and wait and then do the IOL surgery.
Sir, there have been
Sorry, yes.
So there have been multiple studies which combine sequential as well as combined. Sir, we propose that we should wait for at least a month for the corneal remodeling to happen.
That's what I'm asking.
Yes, sir, yes.
If it is more than 2 millimeter,
Yes, sir.
you advise or you advocate that it should be
After the
excised?
pterygium excision. Yes.
and then wait for few months, then do the surgery.
Yes.
And if it is less than 2 millimeter, then
Sir, the significant myopic shift is not more than 0.5 diopters. While going through multiple studies as well as our own conclusion, we found out that if the pterygium size is more than 2 mm,
less than 2.
pterygium size is less than 2 mm, then the overall myopic shift is almost equal to 0.5, not more than 0.5. But if it is more than 2, then according to the size, it varies up to 1.5 diopters as well, sir.
So let me ask you again, please. If the pterygium size is more than 2, you advocate that it should be ideally excised first before the cataract surgery.
Yes.
Okay. If it is less than 2, then what you advocate? Change in the IOL powers
Sir,
or same IOL power?
Sir, we would advise to go for the same IOL power because
And pterygium being a progressive condition,
yes, sir.
what will happen if you...
Sir, if we
Okay, so this is a critical thing I'm just asking.
yes,
Thank
sir. Sir, cataract surgery would be advisable because the refractive correction would be less. But after the cataract surgery, we would advise it to go for a pterygium excision. We can go for in pterygium less than 2 mm. We can go for a combined surgery as well. Combined surgery.
That is what
Yes,
that is
combined
what
surgery
I'm
would have been a better option.
It's a simple answer that if it is more than 2, you do it sequentially.
Yes.
First the pterygium, then the cataract.
Combined
If it is
surgery.
less than 2, then you can do simultaneously.
Yes,
Where
sir.
is the
Combined surgery? Yes.
That's all right.